have to begin identifying what are the gaps, what are the disparities, what are the inequities, and why do they stem? Where do they come from? And I think we start that with this very ambitious and exciting project around patient demographics. That's how we start.
Patient demographic data is significant for the healthcare system because for us to ensure that we achieve the appropriate outcome for all, we first need to know who we serve. We can then target, streamline, and deliver services specifically to meet their needs.
We provide excellent care today, and probably most staff believe that the provision of care does not depend upon culture, race, or sexual orientation, but in point of fact, we don't know that. Whether outcomes vary based on some of those contextual characteristics that patients have, it's important for us to have the information so we can associate the data with outcomes and determine whether our outcomes are indeed equitable.
Well, it's part of the mission of Toronto Public Health to try to improve everyone's health, but also importantly to reduce health inequities. It's a very important feature of the landscape of health in this city. The people's health is very, very different based on how much money they earn, their race, their ethnicity, part of the city that they're in. We need to understand that in order to deliver services to such a diverse population, and this project is critical to achieving that understanding.
One of the key things that's missing right now is concrete data that gives us, real evidence in Ontario around the health disparities that may be faced by certain marginalized populations.
I think the key is that we realize that we're a very diverse city and the needs of our population are quite diverse as well. So we're hoping that this data will help us understand whether our diversity also affects the quality of care that we actually receive. My patients are a very diverse group of older individuals. So they speak many different languages, they live in many different circumstances. Understanding if any of those circumstances or any of those differences actually affects the quality of their health care will help me as a practitioner better understand what I can do to limit those inequities in the healthcare they may be receiving.
A big area of interest has been cancer screening because we all know detection of cancer early on is the best way to beat it. At Massachusetts, they were interested in colorectal cancer screening, and they found that among the Hispanic population, the screening levels were much lower than the white population. The first step was to take this data, break down colorectal cancer screening, and figure out the differences between Hispanics and whites. The second stage was to develop an intervention based on what they identified as possible reasons for that. And then after that, they started tracking. And they found after 6 years that the Hispanic population had significantly increased in their screening rates. In fact, they surpassed the whites by the time they collected the data in 2010.
If we collect data about language, and if we find that an X percentage of individuals that we serve don't speak English, is there a way then to begin to look at whether or not those individuals also face a disproportionate number of adverse events because they didn't understand the care that was being provided or didn't understand when they went home that they were supposed to follow this treatment. So I think that it'll help us begin to make those linkages. And at the end of it all, of course, is quality care.
In our work in public health, equity is central. Inequities based on socioeconomic status, based on where people live, based on ethnicity, based on race. But there's a difference between treating people equally and treating people equitably.
You go to see a concert and 50% of people there are men, 50% are women. When you're looking at the washrooms, there are the same number for men as women, okay? And we know what happens then. There's a huge queue outside the women's and there's a very short queue outside the men's. That is equality. 50% men, 50% women, exactly the same number of toilets. But we know if we want to get those queues down to the same length, we need more washrooms for women than we do for men. Equality is 50%, 50%, same numbers. Equity is looking at the outcomes and saying, if we want the same outcomes, we want to go further than equality. We might need more washrooms for women than we do for men.
Demographic information is actually very important. It helps us define what kind of risks our patients actually have, because the different populations coming from different backgrounds carry different kinds of risks. So one example is that certain groups of patients, certain ethnic origins, have different diets. They eat different things. Some diets, for example, are less sufficient in certain nutrition for pregnant women. So for example, folate is something that's very important for the developing fetus and the baby. And if we don't get enough folate, the baby may have many problems, including spina bifida, congenital malformations, etc. And so we have to ensure that we give them folate supplements so that their babies will be born in the optimal fashion.
In healthcare, we ask very sensitive questions. Clinicians have to ask patients very sensitive information in order to provide care. There's an expectation of that patient-clinician relationship that says it's okay. It's important for this project to learn from how that trusting relationship has allowed sensitive information to be collected, to extend it now to understanding more about the populations we serve. If we understand the people that we're serving on those other dimensions, not just their health dimensions, we will see the whole person living in the community, and therefore respond to the needs of the people living in our community.
In terms of improving health outcomes, we need data, we need the information, and we don't have it, and we can't get it. But I think if we had hard data, then we can start really targeting and going after specific areas. We haven't been able to do effective health planning, and that is something that we need as an Aboriginal community to determine our own health.
We found about 60% of the client population that we see from the African Caribbean population have at least one chronic condition. So now we can say, okay, prevention, education, and management of chronic conditions should be the priority for this organization. Especially we need to target the Black population because we know from the data, right? So those are the kind of data collection and analysis that we're beginning to see.
The first thing I think hospitals will be doing is try to look at outcomes they care about. Here, we really care about birth weight, and so we're going to go back to this data and see, for example, does the income of the mother affect the birth weight of the baby? Does the race of the mother have an impact? And so a lot of this information will really shed light on what are the factors that can explain why babies have different birth weights. Other hospitals can look at cancer screenings, they can look at readmission rates, which is basically one of the biggest cost drivers in our healthcare system.
If we need more resources to address issues within the Black community, we need to show evidence to say, here is where we are. We need some resources to be able to do this and this and this in the community. So education should be part of implementing a data collection process, I think.
We were quite pleasantly surprised that when we told people what we were doing and why we were asking them this information, they openly embraced it. They were more than happy to actually give us this information because, again, they trusted that we're healthcare institutions that want to provide better care.
Members of the public were generally okay with answering these types of questions as long as they knew that it was about improving quality of care. Right? Their quality of care and quality of care for the communities that they were a part of. It's about the comfort of the person that's actually asking those questions. And that's why it's very important for healthcare staff to understand that this is about quality and improving quality, not just for that population, but for everyone we see.
People usually are quite willing to provide you the information if they understand that it's useful for them. So when we collect this information and we explain to them why we're collecting this information, patients usually do not object because they know this is being done for their benefit.
3 reasons why data collection is important: to find out what the problem is, to look at trends of how things are going, to be able to advocate for more resources. If we have those kind of trends and monitoring and evaluation, then it helps us to do more of what is working and less of what is not working.
So it's really about getting people organized, getting people mobilized and engaged, figuring out who our patients are, and taking that information to see if we have the right kind of service for those patients.
You have to have a framework, you have to have accountabilities, and you have to track these things. And you also have to celebrate, as we do in this organization when we do something great.
The Toronto Central Hospitals taking this on as an initiative and leading the way is groundbreaking, it's transformative, and it's particularly significant to the system as a whole and to the profits.